The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are gathered here for the next installment, the next episode of TMD Demystified. I am Tony Urbanek. As I commented on the last episode, which I believe in sequential order was episode 89, this should be episode 90. I commented that this episode is going to focus on unusual cases or interesting cases, which really don't describe what I'm going to discuss today. They're interesting for sure, and they're unusual for sure. And over the past week, I wrestled with how deep I wanted to get into this topic with you. So let me explain a little bit. Please bear with me. Over the past 12 years, as I've gone down this journey of uncovering really what's going on with TMD, both clinically, physiologically, the whole shoot match, and then, of course, what's going on in our system, our dental and medical system, which I've uncovered, I've discussed, I've unpacked, but I've gone down this journey, and what I have found, and I can document this, and that's why I'm doing this episode. I want to document some of these things that I've found that really make you stand back and understand, or try to understand, the scope, the broad scope of symptoms and problems that are created by this thing we call TMD, which is nothing more than inflammation within the temporomandibular joint. Now, I'm going to repeat myself again and again. For those that you watch these regularly, I apologize for repeating myself, but a lot of these episodes are not viewed by someone who's watched all the episodes. They're viewed by someone who this might be their first episode. So we know, and we can document, and we have found, after treating more than 4,000 cases here in Middle Tennessee, in our practice here in Middle Tennessee, and also with an increasing number of cases consistently found throughout our network providers, that inflammation within these joints can cause all of the symptoms: headache, earache, jaw pain and neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of locking. And I've discussed more than necessary, but certainly completely, how that happens. And I refer you to other episodes to review that carefully, but I'll discuss it again a little bit, just the tip of the iceberg, for those who might be viewing for the first time. The thing that was not understood, which was well understood among the orthopedic colleagues, which is the thing that our orthopedic colleagues call joint splinting, where a bad joint, for example, the elbow, will signal the brain stem, the central nervous system, that there's inflammation in the joint. The central nervous system will accept the knowledge, the stimulus, and react to it by sending a motor signal to tighten up the muscles so that you don't move the joint. And that same system works with this temporomandibular joint. All joints work under the same system in the body. It has been totally ignored, certainly totally not even known by dentistry. And they think the joint's so special and it's unique, and it's not unique. But this joint, when it becomes inflamed, sends a signal to the central nervous system through the sympathetic system, the autonomic nervous system, and then the brain stem, takes that signal, modulates it, does whatever it does in the brainstem, which we're not, and we'll talk about a little bit today, and sends a signal out to tighten up. First, the jaw muscles, muscle mastication, then the neck muscles, which can cause upper back and shoulder pain, arm and finger tingling and numbness. And that is, one of the first things I saw many years ago. Patients would come in and they'd say, my arm, hand, finger tingling and numbness is now gone, along with my headaches. Does that have anything to do with my TMJ? And I had to study that, and I had to evaluate the anatomy, physiology of the nervous system and and gross anatomy. And yeah, it does. All right. So with that as a background, that what the orthopedic surgeons call joint splinting, we now know operates with TMD all the time. And if you make the inflammation go away, the symptoms go away. Now, I'm going to just pick on two of the cases that we have uncovered here out of the last 5,000, 4,000 cases that we have treated, that brought to my attention some really interesting findings and brought to my attention some really interesting questions that hopefully in the future, by someone, probably not me, we'll take a look at, and to see if what we have seen here has significant truth and factual and valid and meaningful. So we'll just talk about the first case, and this is kind of on the light side. The second case is a little heavier. Let me see if I can bring up my share screens. There we go. Good. So here's basically what, let me get this set up. There we go. All right, I'm gonna move me out of the way here. So the question is the relationship of TMD to chest pain. Now, this is how it all came about. And again, we're going to talk about two particular problems, and I'm going to show you what, in this case, actually happened. I have had 3 specific patients who have, on the process of doing the consultation and diagnosis and then treating them for TMD, brought to my attention that they went to the point where the pain was so great that it went into their chest and they thought they were having a heart attack. Must have been pretty severe pain. 2 of those patients, all of them, not all of them were males. There were 2 males and 1 female. 2 of them actually went to the emergency department and did a thorough examination and workup for a heart attack for that particular problem, and were cleared completely, and eventually the pain went away. So how can TMD mimic a heart attack? Well, that's pretty easy to explain. Pretty easy to explain. And that goes back to an old slide that I've showed many times on these episodes. And that's why I explained at the beginning how this thing called joint splinting works. When the signal comes back through the autonomic system to tighten up the muscles of first mastication and then the neck muscles, and specifically in and around the scalene muscles, will get tight and squeeze on the brachial plexus. And that is why in some cases, not all cases, but in some cases, when enough pressure, and of course everybody's anatomy is a little different, but when the neck muscles, called the strap muscles, scalene anterior and posterior, squeeze the brachial plexus, and it causes arm, hand, finger tingling and numbness. But as you can see in this slide, there's also a branch of the brachial plexus that comes down here to the pectoralis major, right here, big old muscle. And everybody that works out, they're trying to get their pecs tight, So, but the point is that, you know, when the signal comes through the central nervous system, it always doesn't go to the same place. And it can be bilateral, it can be ipsilateral. And, you know, it is unknown as to the particular nerve itself that's going to be affected. But we've had now 3 examples in this practice within the past 3-4 years of patients who swore that their chest hurt so bad that they thought they were having a heart attack. 1 did not go to the emergency room department, and 2 did, which were then checked out to be totally normal. But they definitely had TMD, and their TMD symptoms cleared completely by relieving the inflammation within the temporomandibular joint, by unloading the joint using the Urbanek device and protocol. So I bring that to your attention because you may not ever see that. I mean, we had to run through like 4,000 cases before we turned over 3 of them. Of course, there may have been others within that group of 4,000 cases that experienced similar things. But when you do a consultation and get in communication with the patient, here's the point. You know, don't blow off some of these symptoms that the patient may bring to your attention. I certainly learned not to blow those symptoms off. I learned early on, that's how this whole journey began. I began listening to my patients. You know the story. After the first 24 people, half of them said, if I put my finger, my tongue, a pencil eraser between my front teeth, gently bite down, it feels better. That's how this all started. Then we had to figure out, well, what does that mean? How does that work? And that's all well documented in other episodes and in the course and in other places. But my point is this, and I'll just say it again for emphasis. You know, as you're doing a consultation, listen to the patient first, listen to their symptoms. You may be able to see some particular dots that when you connect those dots will make perfect sense to you. And in this case, it makes perfect sense to me. Now, can I prove that? No, I'm not sure anyone can prove that. I don't know. I can't think of a study that needs to be done or can be done to like show that on certain occasions, under certain circumstances, that the nerves to the pectoralis major get stimulated to the point that it tightens the muscle and causes severe chest pain. And by the way, keep in mind, muscles don't hurt. Where it hurts is where the muscles are attached to the bone. So the origin insertion of the pectoralis muscles where you'd be feeling the pain, the origin insertion of the pecs. All right, so let's move on to the next one. And this is a little deeper, and I hope I do a good job on this. I'm going to try to, not to lose you and not to certainly intimidate you with more complicated neuroanatomy and you know, processes than necessary. But here is what we found recently. Let me move myself out of the way here. We had a patient, a single patient, and you can't make any judgments by any single patient. I fully admit it. But we had a single patient who came in with torticollis, and I'm going to define and talk about what is torticollis in a minute. But the question that came up, which I'll discuss and why the question came up, is can inflammation in the temporomandibular joint cause congenital muscular or acquired torticollis? So I've done a little research. I prepared myself a little more than usual for this presentation. And so I'll just give you a little insight. First of all, what's torticollis? I remember torticollis when I did my internship at Vanderbilt and medicine. So torticollis, also known as wry neck, is a dystonic condition defined as an abnormal asymmetrical head or neck position, which may be due to a variety of causes. The term torticollis is derived from the Latin meaning tortoise, meaning twisted, and column, meaning neck. So twisted neck. So what torticollis is, and I think you'll see where I'm heading with this in a moment. Torticollis is a twisting of the neck specifically because of stimulation of the sternocleidomastoid muscle, SCM, which causes bending of the neck to one side because of hyper contraction of the primarily, almost exclusively, the sternocleidomastoid, like I just discussed previously to the pectoralis major. Now, can it happen that a signal caused by inflammation in this joint, modulated in the central nervous system in the brainstem, comes back down and says tighten up, in one case, the chest muscle? We've seen that 3 times. Can that also happen with the sternocleidomastoid, which we know neck pain is the second most common symptom of TMD? Headache first in commonality, in frequency. Headache first, neck pain second. So, and my medical colleagues, and I'm not going to read these papers to you that I pulled out, but I can tell you, my medical colleagues, for the most part, have no idea what causes torticollis. There's a bunch of theories. There's some good research done on it, but generally speaking, they admit that they're not really sure what's going on with torticollis, which is contraction of the muscle causing the head to rotate and go down while the chin comes up like this, which is contraction of the sternocleidomastoid. Not real common. It happens in adults and children. That is why there are 2 major categories: congenital muscular torticollis and acquired torticollis. Acquired would be adults, congenital children. Let's talk about the acquired first, and then we'll get to the children, because again, what I've learned and what I teach is nothing more than my ability or use of connecting dots, which I have seen, which explain things which others have not seen. For example, joint splitting and inflammation being the cause of the whole deal. So in torticollis, we had a patient who came in who, on examination and history, had all the usual and customary signs of temporomandibular joint problems. The joints were hot. They had other symptoms, including headache and earache, but the patient also had a big problem, and had for some time problem with torticollis. As we began to treat the patient, the torticollis started to resolve. Now, as I said before, I cannot make any claims on one patient, although it is certainly worth discussing, and further investigation is worth happening. But we know that inflammation in the joint can cause the muscles to tighten up, and if a specific muscle unilaterally gets a signal to tighten up, like the sternocleidomastoid, it will appear to the medical establishment who treats torticollis that it's coming from somewhere and they don't know where. So the other type of category of torticollis is congenital, and congenital torticollis is defined and described as within the first week or 4, between week 1 and week 4 after birth, the child will develop torticollis, contraction of the sternocleidomastoid muscle, pulling the chin up, the head to one side. There are multiple, let's see if I can pull them up here. There are multiple considerations of the cause. Basically, they're not sure. But none of them mention the temporomandibular joint or inflammation within the temporomandibular joint. What was mentioned is that there was some thought about trauma at the time of birth, coming down the birth canal. And we know that, bringing the head down through the birth canal can cause trauma to the mandible, and via trauma or pressure to the mandible, pressure to the temporomandibular joint. And we know that enough trauma to the temporomandibular joint, whether it be in an infant or whether it be an adult, can create inflammation in the joint, at which point, if that inflammation runs through the proper signals, can create a signal to tighten up a particular muscle group or a particular muscle. So wouldn't it be really an interesting study and an interesting concept if treating TMD in an adult will decrease the symptoms of torticollis, and that at least the knowledge of where the inflammation arises in the temporomandibular joint, creating torticollis in an infant, which would be a significant incentive for our obstetric doctors to be more than usual careful on putting pressure on the mandible during birth. This is just a diagram that I pulled off the internet on the cranial nerves within brainstem. And again, I don't want to make a big deal out of this. I think I'll, make you close the episode real quick if I get too deep into this. But this is a diagram of the brainstem and where the nuclei reside, both the sensory nuclei and the motor nuclei of the cranial nerves. And of course, the cranial and the nuclei of the cranial nerve that controls the major nerve that controls contraction of the sternocleidomastoid is the accessory nerve. But this is just a diagram of the motor and sensory, the motor being blue, the sensory being, I call that pink. But and the reason I wanted to show you this diagram is that when the nerve, and this applies to adults and children, it's the same thing, when inflammation within the temporomandibular joint is created, the signal comes back into the brain stem and is modulated actually within the nuclei of the cranial nerves. And I wanted to point out the proximity. That's why I brought the proximity of these nuclei of the fifth nerve, which is here, and the other nuclei, which they're not just, we think of the nuclei as like marbles. Well, they're not. They're, some of them are oval shape or round shape, but the nuclei can be lengthened like this. And the point being that we are not aware of or know much about how there can be bleeding, meaning, wrong word, there can be interaction between these nuclei, which is aberrant, which is inappropriate, aberrated communication between the nuclei, which would, when the signal is actually should come down to V5, it ends up coming down and stimulating V11, which is the accessory nerve, which is what we're talking about here, which is the primary nerve, which supplies motion, motor, sensation, and motor to the sternocleidomastoid, which cause it to contract and cause the problem itself. So I think that I've stumbled along enough, and I hope I've made the point that I've tried to instill some curiosity in the people who are like myself, using the Urbanek device and protocol to decrease inflammation in the joint and, of course, get rid of the headaches and the jaw pain. But there are other potential, well-known, poorly understood episodes or quasi-pathologic symptoms that can occur or may occur. Let's just say may occur, because I'm not trying to prove the point, trying to bring it to your attention. They can occur from just inflammation within the temporomandibular joint, torticollis being one, and definitely pectoralis pain to the point, contraction and pain to the point where the patient's thinking they're having a heart attack. So we've seen a few patients with these symptoms. Can I prove anything from that? No. Do I want to try to prove anything from that? No. What I'm saying is that you need to be aware that this is a strong possibility and that you need to pay attention to your patient's symptoms, and that definitely, as we progress into this journey and our company has the resources to do further studies, within our resources, we plan to do it. So there's two examples of interesting cases that we've seen, connecting some dots and explaining some things that our medical colleagues have no explanation for, like Meniere's disease, which we've already discussed significantly, but I'm not going to go through again. There are 1, 2, 3, 4, 5, at least 5 other topics I'm going to want to cover. And this is what I struggle with as I prepared for this one. I didn't want to get too deep. I wanted to try to just make it as simple as I could to understand. But I have 5 other unusual cases, situations that surprised me as to the symptoms that occurred simultaneously with TMD that may be a direct cause of inflammation within the temporomandibular joint. A couple of them I've discussed before, but only very briefly. I'd like to take a deeper dive into it. And a few of them that I have not discussed before intentionally, because of various reasons. One of them being they'd be very controversial, very, very controversial when I bring this to your attention, controversial by the medical community and others. So don't be afraid of controversy. Basically, just speak on what you see. If you see it, you can document it. That's enough information to speak on it. So for today, I think I've overstayed my visit. I appreciate your attention if you hung in with me. I hope that I've done at least enough to stimulate your thought about how inflammation within the temporomandibular joint can cause unusual symptoms besides the unusual ones we've already identified, some more unusual symptoms. And we have seen several, which we're going to discuss at a later date. I'm not going to try to do it next time. I think I want to mix this up a little bit, but we will spend some time speaking on these other cases that I will research a little bit out, get some things for you to look at, stimulate your thought process, and see if you can line up the dots as you have the ability to do consultations with known TMD patients and to diminish their symptoms. If anyone would you like to make comments or criticisms, they are welcome. Please do. You know, I want to make another comment. This is my count, the 90th episode that I've made, and I've never had anybody comment and no criticisms. Somebody's got to criticize something. It's the United States of America, and criticize something. If you want to talk to me personally, you want to get in contact with me, I am available, but you can easily get a hold of me at Tony@tmjservices.net, Our director of marketing is happy to talk with you if you're interested in joining our network of providers who use the Urbanek device and protocol. We have the study. We can prove what we say. The success rate is through the roof. And you can talk to Naomi at naomi@tmjservices.net. Our website is www.tmjservices.net. For today, I look forward to the next time we can visit. I am Tony Urbanek, and this is TMD Demystified.